Good evening, everybody. Thank you for taking time out of your evening to join us tonight. On behalf of 3Shape and 3DBioCAD, we'd like to welcome you to our webinar tonight featuring Dr. Michael Park. Dr. Michael Park is a board-certified periodontist and prosthodontist, receiving his DDS degree from University of Alberta. He will be speaking to you all tonight about implant restorations and digital impression scanning. So I hope you enjoy our webinar tonight. Dr. Park, do you want to take it away?
All right, so let me just share my screen with you guys. All right, hello everyone. My name is Mike Park. I'd like to welcome you to today's webinar. Today's webinar topic is temporary restorations and digital impressions on dental implants. So let me just go over the outline of today's presentation with you guys first. So first thing that we're going to go over is the temporary restorations. Why do we do it, and when do we do it, and how do we do it? So we'll talk about immediate temporization, and we'll talk about custom healing abutments and delayed temporization. And after we talk about the temporary restorations, we'll talk about implant digital impressions, and we'll talk about the workflow of doing implant impressions for implant-supported crowns, implant-supported FPDs, and full arch implant-supported FDPs. So let's start with temporary restorations and why do we do them? One of the obvious reasons is to replace missing teeth temporarily and also for patient comfort, because compared to interim partial denture or a S6 appliance, because it's a fixed restoration, it's much more comfortable for the patient. But ultimately, the reason why we do implant temporization is because we can actually change the shape of the gum tissue. So we can push the gingival margin up if we want to by adding more material to the emergence profile, and we can actually subtract material from the emergence profile and bring the gingival margin down. So we have the ability to alter and mold the soft tissue with our temporaries. So rather than going straight to the final restoration and not being able to adjust that soft tissue contour, with a temporary we can make these adjustments. And once we're happy with our final gingival contour, then we can take an impression and do the final restoration. First, let me talk about immediate temporization. So on top of the benefits of doing temporization, there are added benefits of doing immediate placement and immediately temporizing the implant. So one benefit is that you preserve the soft tissue contour. When we extract the tooth, we are able to maintain that original gingival margin by placing an immediate temporary crown. And also that temporary crown can act as a barrier and keep the bone graft particles in place so that we don't lose any bone graft particles during the healing phase. So I'd like to share a technique with you where I'm using a natural tooth as a temporary restoration. So in this case, the laterals of this patient had severe root resorption, so they had to be taken out. And we decided that we're going to do immediate implant placement and immediate temporization. So one important thing when we're doing extractions in these cases is that it's really important that we don't damage the soft tissue. And obviously, the reason why we want to preserve and not damage the soft tissue is because ultimately with the immediate temporization, what we're trying to do is preserve the soft tissue contour. So if we, let's say, traumatize it, or if we flap the area, then there's no more soft tissue contour that we can preserve. So we need to be really careful when we're extracting these teeth. And then we place the implant, and we need to place these implants flapless for the same reason of preserving the soft tissue contour. And we can only immediately temporize if we do have adequate primary stability. And one way of testing that primary stability is the insertion torque. So if the insertion torque is 35 Newton centimeter or greater, then we can immediately temporize. and in this case, the insertion torque was above 35 Newton centimeter. And then we placed the temporary abutments in, and I adjusted the temporary abutments so that the temporary shell or the natural tooth that we're using can seat in place without interfering with the temporary abutments. And then we hollow out the natural teeth so that it doesn't interfere with the temporary abutments. And then we basically position these temporary teeth that we're using in the correct position by placing it in the vacuum form matrix and then seating it. Now at this point, the temporary teeth are in the correct position, temporary abutments already on the implant. Now all we need to do is basically connect these two, and what I use for this is I use a flowable composite for this. And then after you connect it inside the mouth, you take it out, and basically now all you need to do is fill in the gaps and voids. So we create the emergence profile using flowable composite and fill any other voids that are present with flowable composite as well. And then now we can, we're ready to polish the restorations. We polish it really well, and we clean the temporary crown really well too. Now it's really, really important that it's really well polished, and also that there's no debris and polishing paste on the restoration. So what I like to do is I like to use a wet gauze and just wipe the temporary really, really well, especially the subgingival part of the temporary restoration. And then I use a steamer to steam and clean up all the debris and that kind of stuff off of the temporary restorations. And now that the temporary crown is ready, we are ready to graft the gap with bone grafting material. So what I do is I place a narrow healing abutment on the implant, and I pack bone graft particles around the implant, like you see here. And then now very carefully we remove the healing abutments, and then place our temporary crowns. And it's a screw-retained temporary crown, so we insert it. And as you can see, because we didn't damage the soft tissue much during the extraction, the soft tissue looks really, really nice, and soft tissue contour now can be preserved. However, I want you to look at the black triangles that are present adjacent to that site. And the reason why we do get these black triangles, even though we were very careful with the extraction and the whole procedure, is because as soon as we take a tooth out, and if there's no support for that soft tissue, the soft tissue is going to collapse. But once you put that support back in, if you look at the 2 weeks healing, you'll notice that the soft tissue will grow back and fill back because now it's supported again. So now if you look at the 2 weeks post-op, you can see that the healing looks really, really nice, considering that we took the teeth out, we placed the immediate implant, we did the bone grafting, and so considering all that, the healing looks really good for 2 weeks post-op. So generally with this type of procedure where we're doing immediate implant placement and immediate temporization, the healing is really, really good. And then now if we compare it to the pre-op, you'll see that basically nothing has really, really changed when you're looking at it inside the mouth. But of course, we know that the teeth are out and the implants are already placed and bone grafting was done. So using natural teeth as a temporary is a really good technique. You can get a very good result, but obviously you can't use that technique for all cases because sometimes the existing tooth will have large decay or a lot of restorations on it. So it's not a technique that you can use all the time. So I'll go over a technique that I use for most of my immediate temporization cases. So what I do is I create a shell temporary with a positioning jig attached to it. And Jack will later go over on how to design this type of restoration on the 3Shape software, but I'll go over the clinical steps of doing this. So basically, with a shell temporary with a positioning jig, what the positioning jig does is it places a temporary shell in the correct position, and then basically all I need to do is after the implant goes in, I place the temporary abutment on and connect the temporary shell to the temporary abutment, and then remove it and then fill in the space. So let me go over these steps one step at a time. So first we place our implants, and in order for us to immediately temporize the implant, the insertion torque needs to be, like I said, at least 35 Newton centimeter, and it was in this case. So the next step is to place the temporary abutment on the implant after the implants are placed. Now, when I do this, I like to apply a opaque flowable composite onto the temporary abutment, because if we don't apply this opaquer, the metal will show through the temporary, and then the temporary restoration will look gray and dark. So obviously we don't want that. So we need to be able to block the temporary abutment color. And in order to do that, I use the opaque flowable composite like you see in this slide. And the next step is to seat the shell temporary with a positioning jig. Now, when you do this, the temporary abutment might be touching the temporary shell. So one option is to adjust the temporary abutment, and the other option is to adjust the temporary shell. So what I like to do is I like to adjust the temporary shell because it's much easier to grind acrylic than to grind metal. And to adjust the temporary abutment, I don't like grinding it inside the mouth, just because then the metal particles will go everywhere and might contaminate the surgical site. So obviously we don't want to do that. So you end up adjusting it outside the mouth, which I think is quite hard to do. So I like to keep my life very, very simple, and I make the procedures very easy. So what I do is I adjust the temporary shell. So basically I adjust it until nothing's touching. And then what I do is I simply attach the temporary shell to the temporary abutment using flowable composite. And when you do this, it's very important that you don't inject the flowable composite too apically, because that might contaminate the surgical site. So what I do is I inject it around the coronal third, and sometimes I go down to the middle third if necessary. And once everything is all connected, now we can remove the abutment screw and then remove the whole temporary restoration. And outside the mouth, what we can do is we can basically just fill the gaps, fill the voids using flowable composite. So we fill in the emergence profile and any voids that are present, like you see in this slide. Okay. And after we do that, now we remove the positioning jig and then the temporary abutment that's sticking outside the temporary crown. And then now we're ready to polish the restoration. So we do the polishing. And then, like I said before, we want to clean off all the debris. So wet gauze and wipe especially the subgingival part of the temporary restoration, and then steam the restoration so that it becomes really, really clean. And then now we insert the temporary restoration onto the implant. And one thing that you want to make sure with these implant temporaries is that you don't want any occlusion in centric and in eccentric positions. So you want to make sure that nothing's touching. So basically what I do is I put articulating paper in and get the patient to tap, 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 and grind side to side and front and back. And if there's any marks on the temporary restoration, I adjust it. So if you look at this temporary crown that I did, you'll notice that the incisal edge is slightly short, because patient, when they go into the edge-to-edge position, there was contact in that area. Now, if you look at the 2 months post-op, as you can see, the healing looks really, really good, and soft tissue contour looks really, really nice. So I have tried many different techniques to do the immediate temporization, and I find that this, although you do need to have your the lab, or if you have an in-house lab, you have to have your in-house lab make this temporary shell with the wings. I think it's worth it because first, it's very, very accurate. So it positions the teeth in the correct position. So you don't have to struggle positioning the temporary in the correct position. And it actually saves you a lot of chair time when you're doing this. So I highly recommend this technique if you haven't tried it yet. The next thing that I'll go over is custom healing abutments. So why do we do custom healing abutments? So it has the same added benefit of as doing an immediate temporary crown after immediate implant placement. You preserve the soft tissue contour, and it acts as a barrier for the bone graft material. Then when do we do immediate temporary crown, and when do we do a custom healing abutment? So like I said before, with the immediate temporary crown, we need at least the insertion torque of 35 Newton centimeter. But sometimes we don't achieve that with the immediate immediate implant placement. So if the insertion torque is anywhere between 20 to 35 Newton centimeter, then that's when we will be doing the custom healing abutment. So one downside of custom healing abutment compared to the temporary crown, obviously, is that it will not replace the missing teeth. So you do need another way of replacing that missing teeth temporarily. Now, if the insertion torque was below 20 Newton centimeter, at that point, I don't want any healing abutment on the implant and have it stick out. So what I do is I place the cover screw and just bury the implant so that the implant can heal undisturbed. So let me just share the technique of doing a custom healing abutment with you guys. So more or less, the way I do my custom healing abutment, the technique is very, very similar to doing an immediate temporary crown, as you will see. So before we do the extraction, I'm always planning on doing an immediate temporary crown if possible. But if I don't achieve the primary stability needed in order to the immediate temporary crown, I will be doing a custom healing abutment. So if we look going into the surgery where we're extracting the premolar, I have the shell temporary with the positioning jig ready. And then we take the tooth out and place the implant. In this case, the insertion torque was between 20 to 35 Newton centimeter. So we're not able to do an immediate temporary crown. So what we do is we're going to do a custom healing abutment. But as you can see, we place the temporary abutment on the implant, and then we place the temporary shell temporary with the positioning jig. So up to this point, it's exactly the same as doing a temporary crown. And then we make sure that it does not touch, the temporary shell does not touch the temporary abutment, and we adjust the temporary shell if it is binding. And then basically we connect it with flowable composite, just like we did with the immediate temporary crown. And then we remove it from the mouth. And outside the mouth, we basically do the same thing as the immediate temporary crown. We fill in the voids, the emergence profile region, with flowable composite. Now, at this stage, when I fill in the voids, I don't use, you can use pink composite, pink flowable composite. That's one option. Another option is to use tooth-colored flowable composite. However, if you are planning on using a tooth-colored flowable composite, what I'll recommend is use a shade that's different from the shell temporary. So let's say your shell temporary was a shade A3, then what I would use is I would use a shade A1 flowable composite to fill in the emergence profile region. And the reason why I do this is because then I know where I need to cut. What I mean by that is the junction between the newly added flowable composite and the shell temporary, that's where the gingival margin is, because that's the way we designed the shell temporary. So then I know that that's the gingival margin. Now, if when we do these custom healing abutments, we want the whole purpose of doing this is to support the soft tissue. And if we make this custom healing abutment subgingival, then obviously it's not doing the supporting. So in those cases, so in these cases, when we're doing the custom healing abutment, we want to make sure that we leave some custom healing abutment above, or it needs to be at the gingival margin. So by using a different shade composite to fill in the emergence profile, and then I can easily identify where the junction is between the shell temporary and the flowable composite. Now I can adjust right at the junction, or I can adjust slightly chronal to that junction so that I know that the soft tissue will be supported. Okay, now this is how it looks outside the mouth. And then now that the custom healing abutment is ready, now we're ready to do the bone grafting. So what we do is we put a narrow diameter healing abutment, and then we pack the bone around the implant. And then very, very carefully, we remove the healing abutment from the implant. And then we very carefully place the custom healing abutment into the mouth, onto the implant. Now, if you look at the picture on the right, that's right after the surgery. As you can see, it goes right to the gingival margin. And this is 1 week healing. So as you can see, like 1 week healing looks amazing. I don't think there's other surgeries that I can do to have this kind of healing. So it's actually quite a nice technique. So I like doing, whenever I can do immediate implant placement and do temporary crowns or custom healing abutment, I'll be doing that because the result is very, very good. So soft tissue contour is well maintained. The bone graft particle is well contained. So we get minimal shrinkage happening on the buccal aspect if we do use these techniques. The next step is we're going to talk about delayed temporization. So for whatever reason, if we weren't able to immediately temporize the implant, then we're going to do a delayed temporization just because we do want to alter the soft tissue contour and mold the soft tissue around the implant. So, of course, what you can do is you can have the shell temporary with positioning jig made and do this inside the mouth. However, at this point, the implant's already integrated, so it's much easier to take an impression. So in our office, we use trios to do our intraoral scanning with the scan body on the implant, and then we send that to the lab, or actually our in-house lab, and at our in-house lab, we'll make the temporary crown. So they'll design it on the 3Shape software, and then we use a tie base and we cement the milled temporary restoration onto the tie base, and then we basically, what I do in the clinic is basically just insert that because it's a screw retained restoration. The temporary material that I like to use is DGShape by Ivoclar. I find that the color is warm and it looks quite natural for a temporary. And when I did more and more of these delayed temporary restorations, sometimes what I did get is I actually got the temporary crown debonding from the metal tie base. And the area that would debond is the junction or the interface between the cement, the resin cement, and the temporary crown. So in order to minimize this from happening, what we do is we sandblast the internal surface of the temporary crown with 50 micron aluminum oxide. And then of course you can sandblast the tie base if you would like, and if that's what the manufacturer recommends. And then in order to cement this, what we do is we inject light body PVS into the access hole so that when I'm cementing the crown, temporary crown, excess cement does not go into that access hole. And then, of course, you can wait for that PVS, light body PVS to set and then cut it off with a blade, or you can just, when it's, before it sets, you can actually just wipe it with your finger, and I find that that's a little bit easier. And then what we do is we apply Scotch Bond Universal onto the tie base and the internal surface of the temporary crown. And then the cement that we use for this is multi-link hybrid abutment HO. We like this cement because it's very, very opaque, so it'll mask the metal color. And then after you cement it, you clean up the excess, and that's how it looks. So for me, like as a clinician, it makes my life very easy because I don't have to spend time inside on the chair trying to make the temporary crown while patients waiting there. So this is really nice. So all I need to do is remove the healing abutment and insert the temporary crown. And of course, you need to, after you torque it, the temporary crown down, you need to cover the access hole. I like to use Teflon tape, and then of course you will apply the adhesive, and then I use flowable to close the access hole. So I just went over how I do my delayed temporary crowns. I'll go over how I do my delayed temporary implant-supported FPDs. So whether we're doing an implant-supported crown or temporary implant-supported FPD, we need to have adequate soft tissue volume. So we can't really shape the soft tissue to the correct shape if we actually don't have the soft tissue to begin with. So if you look at this case, implants are already placed on site number 6, 8, and 10. But as you can see, the soft tissue volume is quite lacking. Vertically, it seems okay, but horizontally, we're lacking quite a bit of volume. So in cases like this, we need to do some soft tissue grafting first before we can actually shape the soft tissue with our provisionals. So let me just briefly go over the surgical technique that I used for this case. So I harvested connective tissue from the palate, but as you saw from the previous slide, the amount of augmentation that I had to do is quite a bit. So a single layer of connective tissue would not give me the adequate volume that I need. So what I did was I layered a cellular dermal matrix under the connective tissue and then sutured it together. And the technique I decided to use to place the graft is a single incision technique with a tunneling technique. So I made a single incision right down the midline, and that's the only incision I made in this case. And then I basically created a tunnel on the right side and the left side and placed my graft through that single incision into the tunnel. And then after I did that, I sutured it and I placed positioning sutures like you see on slide 5 or picture number 5. And if you look at picture number 6, what you'll notice is that we actually were able to gain quite a bit of volume from this soft tissue grafting. And if we look at the 6 months post-op and compare that to the pre-op, what you'll notice is we actually gained enough volume. Now we're ready to shape the soft tissue with our temporary restoration. So now next step is to uncover the implant. Because the implants were placed guided, I know exactly where the implants are, and all I need to do is position the surgical guide back on, and because I have adequate keratinized tissue and adequate ridge volume, I can do a punch technique to expose the implants, and then I take the impression and send that to the lab so that the lab can fabricate a delayed temporary milled PMMA implant-supported FPD with Ove Pontic. So let me just go over how I develop the Ove Pontic site and how I deliver the delayed temporary implant-supported FPD. So if you look at picture number 2, when I'm trying to insert that temporary implant-supported FPD, what you're going to notice is because there's too much soft tissue in the area, the central pontic is stopping the temporary bridge from fully seating. So in order for me to adjust the soft tissue, I need to know where it's binding or where it's contacting. So what I do is I use a occlude spray on the intaglio surface of the pontic, and then I try to seat it. And then it will leave a mark like you see on picture number 5. So all I do now is I use a KS5 burr. It's a coarse diamond tear-shaped burr, and then I remove the green marks using this burr. And I repeat this process until I can fully seat the temporary bridge. And this is how it looks once it's fully seated. This is immediate post-op of the site of the insertion of the temporary bridge. And as you can see, there's a little bit of blanching, and that's what we want, right? We don't want to adjust the soft tissue too much that there's a gap underneath the pontic. That's not what we want. We actually want a slight compression so that we get a little bit of blanching. And what this will do is it'll actually push the soft tissue into the interproximal area and buccally so that we get a pontic that looks like it's coming out from the gingiva. So of course, the soft tissue is a little bit irregular at this point, which will need to be plastied later. But if you look at the pontic itself, it looks like it's coming out from the gingiva. So it actually looks quite good. Okay, so that's how I do my delayed temporary restorations. Now that we create a nice emergence profile, now we need to transfer that information to the lab. And traditionally, I used to do a traditional impression with impression copings and sent that to the lab. But now I switched over to doing everything digitally. So I use a Trio scanner to scan my implants. And of course, instead of using an impression coping, now we place a scan body onto the implant and do an intraoral scan. And that will transfer the implant position to the lab, and the lab will be able to create a digital model and make a final restoration for you. So yeah, that transfers the implant position, but what about the soft tissue contour that we have created using a custom healing abutment or a temporary restoration? It doesn't necessarily transfer that soft tissue contour very accurately if you just use an intraoral scan inside the mouse. So I'll just go over a technique that I use to transfer this information for an implant-supported crown. So if you look at this case, when I do the scanning, I click on in the order form, I click on the pre-prep scan. So with the pre-prep scan, I leave the temporary crown inside the patient's mouth. So number 8 is the implant temporary crown. And I do the scanning. And then after that, I take the temporary crown off and then place a scan body and do a scan body scan inside the mouth. So this will transfer the implant information to the lab. And then I do a third scan in a different order form. So I scan the temporary crown outside the mouth. So basically what I have on the picture on the left is lab analog mounted in resin. So the resin that I use here, I used a custom tray material, which is readily accessible for me. So I use that to create that block. And then I basically place my temporary crown and screw it into the lab analog, and then I do my scan. If you try scanning the temporary crown while holding it, I find that it's very, very difficult for me to do that. So that's why I put it on a block like this. But yeah. And then the reason why I do this scan, a separate scan of the temporary crown outside the mouth, is because if we scan the soft tissue, so once we take the temporary crown off, take it off from the implant, what's going to happen to the soft tissue is it's immediately going to collapse. Now, and sometimes what you'll notice is when you take the temporary crown off, it might bleed in that area. So obviously, if there's blood, you're not going to get an accurate scan. So you're going to rinse that area, you're going to dry it, and then you're going to scan it again. But now at this point, now the soft tissue is not, the contour is not the same. And you spend all that time and effort to creating a nice soft tissue contour with your temporary. So you want to be able to accurately transfer that to the lab. So now if you look at the image on the right, so it's I superimpose the temporary crown that was scanned outside the mouth with the body scan that was done inside the mouth. Now, if we look at that green box, if that soft tissue contour of the body scan was very accurate, that pink line, which is the body scan, should overlap with the blue line, which is the scan of the temporary crown that was done outside the mouth. But obviously, it does not overlap, which means that the soft tissue has collapsed. So that's why I do another scan like this, scanning the temporary crown outside the mouth. So basically, the lab will have all these information. So the pre-prep scan and the body scan and scan of the temporary crown outside the mouth. And then now, if you look at the video on the right, they'll be able to superimpose all these information. So they'll have the information of the implant position. They have the emergence profile information, and have, of course, the adjacent teeth and the bite. Of course, you do this opposing scan and the bite, of course, with this type of scanning. So that's how I do my implant-supported crown impressions or digital impression. Now, I'll talk about how I do my implant-supported FPD impressions. So more or less, it's pretty much the same as doing implant-supported crown digital impression. I do the pre-prep scan with the temporary crown or temporary bridge inside the mouth, like you see on the left. And then I remove the temporary bridge and then I place the scan bodies on the implant, and then I do the scan body scan. So now this transfers the implant in position to the lab. And then I place the temporary bridge onto that temporary abutment block that I showed you earlier. And then I do the scan. Now, with this scan that's done outside the mouth, I'm recording the emergence profile of the implant temporary. And also I'm recording the Pontic design of number 8 and 9. And another information that I do send to the lab is a retracted full face picture. So this, I do this instead of doing a traditional face bowl. So we call it a digital face bowl. And using this picture, what the lab will be able to do is they'll be able to digitally mount the upper scan to this picture. And so digitally doing the face bowl. And then if you look at the video now, the upper jaw scans mounted, like digitally mounted, and then we have the scan body scan also superimposed. Now we have the temporary bridge scan there as superimposed as well. So now we have the information of the pontic design, emergence profile, and the implant position and everything, and then also the face. So now the lab will be able to fabricate a nice looking final restoration that will not alter the soft tissue contour, because they will copy the emergence profile of the temporary and the pontic design of the temporary. So finally, let's talk about a full arch implant-supported FDP digital impressions. So if you look at the picture on the top, that's the immediate temporary restoration that we delivered when we placed the implants on the top. And if you look at the bottom, I place scan bodies on the implants and do the intraoral scan. So it's actually quite similar to the previous scans that I do. So I do a pre-prep scan, and the pre-prep scan, just like before, I scan the temporary restoration inside the mouse. And then and then after that, for the scan body scan, we place scan bodies onto the implants and do the scan body scan. But unlike the previous scans where we had teeth to use as stitching points, we don't have that once we remove the temporary bridge, because it's a full arch bridge. So we need a common stitching point. So sometimes on the palette, we can use Ruge as a stitching point to superimpose these two scans. But I like to apply flowable composite dots onto the palette and use that to superimpose these images together. So basically what I would do is I would click on the pre-prep scan and then do the pre-prep scan like you see on the left after applying the flowable composites on the palette. And then I would basically trim out the temporary restoration. And then when I'm starting to scan the scan body scan, what I would do is I'll start scanning the palette first, where we have those markers, and then go over the other areas where the scan bodies are. Now the scanner will be able to stitch these really well together. And of course, there are other informations that we need to send to the lab too. So just like the previous case, in this case, we need to send the full face photo so that the lab can do a digital face bow. So if you look at the video on the upper right side, our lab has digitally mounted the upper scan to the face. And then if you look at the video on the bottom right side, you can see that the scan body scan and the pre-prep scan are superimposed and stitched together. Now we have the scan body scan mounted on the face as well, because they're stitched together. And then now we have the implant information, position information in the correct position inside the patient's mouth or virtual patient mouth. So now the lab has all the information it needs to do the restoration. However, what I like to do is, what I noticed that is with the scanning, if I'm using scan bodies and doing the digital scanning of the implants for full arch cases, sometimes it is not 100% accurate. So I definitely want to confirm that the implant position, I want to confirm that the scan was accurate. So what I do is I do use a little bit of analog technique where I make a verification jig. So basically what I do here is I insert the temporary abutments onto the multi-unit abutments, and then I basically connect them inside the mouse. Now the lab will be able to use this to see if the implant scan was accurate. And then another check that we do is we make a temporary full arch bridge, like you see here, and then we try this inside the patient's mouth to check the to see if the restoration is passive, and we also check the aesthetics, phonetics, and also we check the occlusion as well. And if anything has to be adjusted, we make the adjustments to the temporary, and we'll send that back to the lab, and then the lab will make us the final restoration. So as you can see, I wish I had more time to show you the traditional workflow and compare the digital work, the scanning protocol to the traditional impression protocol. Because the digital protocol is much, much easier, and it's just as accurate, if not accurate, and we're able to transfer the soft tissue contour really, really well to the lab. So If you enjoyed what you've listened today, we do provide a CE course at our office on implant restorations, implant surgery, guided implant surgery, bone grafting, and soft tissue grafting. So if you are interested, please come check it out at clear-dental.ca/education. Jack will now go over the 3Shape software and how to use a 3Shape software to do some of the things that I did talk about in this presentation. Thank you.
Thank you very much, Dr. Park. Thank you so much. Share your knowledges, and then it was very great presentation, same as before. Let me take over the screen, and probably I just share my screen on here. So hi everyone, my name is Jack Jung. I'm from 3DBioCAD, who work with 3Shape very closely. And we saw just like very nice Dr. Park's like clinical side of how we make immediate provisional, and also how we're taking very nice digital impression too. To my side today, tonight, I'm gonna go over about the implant restoration with a little bit of the digital impression way too. Similar with the Dr. Parks, and then I just focus on a little bit right after provisional work too, as like view as like a laboratory side who does do the CAD/CAM work, okay? So let me get into my page here. What I want to show you today is this. First of all, I'm going to go over immediate temporary provisional crown, which we just saw in Dr. Park's presentation. I'm going to show you how we could make some shell with wings. I'm going to just quick view with the 3Shape software itself. And then digital impression, which we just saw with the Trios intraoral scanner for implant restoration. And I'm going to just point it out what we have to focus on. And then next thing, we're just gonna quick view about the CAD/CAM abutment, not like traditional way. We already know about it with UCLA. So we're gonna focus on what we could make with CAD/CAM workflow. And then last thing, full arch restoration about the like Roland 4, Roland 6, many doctors just try to do or already do a lot. And recently we have many ideas and then workflow coming out. And I wanna introduce one of way to making Roland 4, Roland 6 implant restoration tonight, okay? This is my first page about the shell. So we know, yes, we know about the shell provisional crown for implant immediate temporary crown. We could prepare the shell crown, and then on chair side, doctor, dentist can do reline on bottom side and creating nice emergent profile. Yes, we do know about it. And what the point is here, this design is I just do myself with 3Shape dental system. And as like Dr. Park, who has a milling machine, just can mill in-house too. If not, can sending out to the lab, okay? Or just lab do design and mill everything for you. And for this provisional on the photo, I mill out with a wet milling machine, PMMA for shell. We could mill by dry mill and also wet mill too. But what's a good point with the wet milling is after mill, the surface of the PMMA is very smooth and shiny. So we could save time to finishing and polishing work. That's the benefit for that. So for the shell, I'm not sure you have seen the dental system, which is a 3Shape design software before or not. Let me just quickly taking tour for you here. So I just opened up the dental system design software, which name is a dental system premium here. And this is very similar case for number 8, one single implant will be placed, and then we want to prepare shell crown, okay? So within dental system by 3Shape, we have function to design the crown, of course, and then you already recognize, and if you saw before, we have the function to mirror copy function. I just duplicate from number 9 for number 8 design, okay? And what the point is, once we have a full contour of the very nice design on here, in the dental system, is very up to how we set the work order from, but I could add 2 more, the neighbor crown, as like a fake crown, but I could make just like modify very quickly, and then I can creating and changing as a wing. So these 2 wings will be connect to the number 8 shell. And then within dental system by 3Shape, the shell provisional design software has a function to make hollowed out from the full contour design. And also we can set the thickness of the shell too. So it's very up to your taste. If you want to have like thin as much as possible, you can go thinner. But of course, we have to keep the minimum thickness to avoiding breaking the PMMA. But for implant restoration, if you want to make a little thicker than normal crown shell, of course, we can set it up ourselves in the design system. So simply, we have all the tools and primary offset settings in the designing period. So for shell and also for wing, we could make with a dental system from 3Shape, okay? Let me go back my presentation. This time, after the normal shell, I want to introduce another way to prepare the immediate temporary crown, which is combine the Implant Studio, the implant surgical guide software, plus dental system, which we just saw. So we do know the digital surgical guide software. We do have chance to planning, or before planning, we can do digital wax up, implant planning, and also we could make surgical guide on top of there. But what's good point with the 3Shape family softwares are this. Implant Studio from 3Shape and dental system from 3Shape is just like same company's software. So that software file, software working file, the software information can be integrated each other. So which meaning is once I place the implant position for surgical guide into Implant Studio, after that, we can export out the file, which is placed of the implant. We can import into dental system for shell design or screw retain shape design. So if you see on my photo, the left one here, I did make surgical guide with my doctor, and also at the time I did design and mill screw retain shape of PMMA bridge. So doctor did use surgical guide first and use this milled PMMA, which is high polished, and then doctor use temp cylinder and do the just like minimal relining work. So on the right side, just before and right after surgery, and then week after post-op photos here. So again, we can prepare shell and do conventional work on your chair side, or we could prepare both digital way for surgical guide and screw retain immediate temporary bridge or crown too. Okay. One thing, normally for this way, for the left side, actually I couldn't cement it for my doctor because never know the implant angle or depth or the engaging could be a little different with the implant planning. So please keep in your mind. Okay. Let's go to the next view. Let's talk about the impression with the digital workflow. We saw how the Dr. Park used a 3D intraoral scanner, and we didn't know about that. And what I want to point in here is this. So the first step, always we should understand and we should use scan body. We call the scan body. Someone calls scan abutment. Someone says some scan flag, but mostly we call the scan bodies. Same as like impression coping. With the stone cast workflow, we want to placing on and we use desktop scanner for that. For intraoral way, we place the scan body in the patient's mouth and use intraoral scanner. We do know, yes, on chair side, yes, we do every day. And third thing, what I need to point it is the CAD library. Okay, so clinical side for doctors wise actually doesn't really need to understand what is a CAD library is, but it will be very good to know because if you see like small map on here, we can see multiple elements are there because when the implant company making some part scan bodies, titanium bases, some implant analogs, they make like a CAD map, which is they all combine on the same position as like this view. So scan body will offer the analog position, just like a transferring, same as like a traditional work. So we call this library for the CAD. And the last step on the lab software for the design, we do align rear scan body images to the library scan body. After that, we could have analog position. So if you ask me, Jen, what is the most important part? Of course, I want to say everything, doctors. But why is everything so important with this first step is this. Let's say that. Okay, the first one on the very left, I'm sorry, so many things are here, but I want to just point it out one by one. The scan body for working in the intra-orderly, the main thing is when we work with the stone cast, I just making soft gum tissue and then taking out and then put the scan body on the analog. So I could very easily see the scan bodies all the way down on the analog or not. But how about the intra-orderly? So if implant is a little depth, and then for prosthetically, for good aesthetic and for good emergent shape, most doctors want to place the implant around the 3 to 4 millimeter under the CZA line. So that meaning is scan bodies always go under the gum tissue. So with this region, sometimes it's very hard to recognize scan bodies all the way down or not. Okay, so the best way for best result after put the scan body on the patient's mouth, I just recommend the taking one just like quick X-ray and then making sure the scan body's connection is all the way down on the implant fixture or not. That's the first step, what we have to care. Okay, and the second thing is this: once you place the scan body well in the patient's mouth, and then if you scan with the intraoral scanner, but of course there's like many different intraoral scanner, but of course I want to mention of the Trias because I'm a big fan of Trias. So Trias has like very nice and high accuracy of the accuracies with the turnitin and the precision, and compared with the other comparable scanners, competitor scanners, the intraoral, like Trias intraoral scanner has almost like zero error accuracies there. So the first thing, we have to place the scan body on the right position. Second thing, we should scan with accurate scanner with good skill. I'm going to talk about skill a little later. And then third thing, laboratory side, we should understand the library and we should do align well and design well. So I can say the first two steps need to carried by clinical, and then the later two steps, the laboratory guy should care. We should use right, correct library for the CAD, and then we should do right work in the design software for superimpose aligning scan body images. And we can expect at least like a scan and CAD side, the accurate work, I can say that. So like printing model or milling something, we could think later too. But to me, normally I just want to make 3 or 4 separate steps for finding out the good way to making an accurate restoration, scan, CAD, and CAM, not just only CAD, CAM, okay? So next page, I think just everyone already know about it, but just let me just point out very quickly about the what kind of the titanium part, because most case recently we go with the titanium a lot. So we could make just custom abutment with a screw retained crown, or we can just use titanium base with a screw retained style. And the third thing, the angled screw channel titanium base. Many doctors, many laboratory guys looking for that recently, right? I think everyone agree with that because we can just cover the bad implant angle and then we could make screw retained type. But I would recommend, and I would really want to tell you guys, doctors, please don't just think every implant brand, every implant system, every implant kit is possible with angled screw channel type base, because it's very, very up to implant companies. Some companies are already ready to using it. Some companies are ready, but is partially ready. Some companies implant part is ready, but only milled by the centralized mill, like an implant own authentic milling center only. So whenever you have a chance and then plan to do making angled screw retain screw channel, the restoration with the tie base, please discuss with your laboratory guys first, okay? yeah, it's going on with that. So we just saw the titanium work, and we doing many cases with the titanium custom abutment, but I just prepared one zirconia titanium hybrid abutment case just for the view. Okay, it's just case by Dr. Karchimich before with our sister lab, B&B Ceramic Art. We can see on the left side zirconia abutment shape there, and then inside there, of course, we have tie base. Okay, so that's why we call it hybrid abutment. And what a good point is, we can see the CZ around margin area. Even if the gum tissue goes down, the zirconia teeth color going to show up, so we can prevent like titanium or gold color it falls out from the patient's facial. So that's the first benefit. And then of course, the stem color of the abutment, instead of the gold or instead of the titanium silver metallic color, we could expect the good like natural tooth stem shade. But of course, always we cannot have good point only. So when we're making zirconia abutment with the titanium base, we should think about implant has to be deep enough, and then the emergence has to be wide enough, and also the tooth, the room for with the neighbor and with the antagonist, we should have enough room for making the room for tie base, zirconia abutment, and crown on top. So once you're making crown on top of here, like this photo, and in the patient's mouth, he looks very happy. So we saw this just same case under Dr. Park's presentation. I just got this file from him, and I want to point out one more time about how we set it up in our trios. Okay, in the trio system, once we pick as implant restoration, and we can add pre-preparation button on your trios. Okay, and then we're gonna have 3 different steps for the scan: pre-preparation with nice provisional, and then preparation scan with for only gingiva, okay, and then scan body scan. So what we have to care with the step by step, the first step for pre-preparation with provisional, of course, we want to scan whole arch with the neighbor teeth and all the teeth around following the 3Shape's recommended scanning path. Yes. And then second, for gingiva, of course, we want to capture that emergent shape. But as Dr. Park saying, it could happen like collapse right away. So we could think about that too. And third thing, the scan body scan like this. But reason why I pointed out with little wider range than the gingiva is this: as we know, all the intraoral scan workflow or the technologies are this: capture the images and then render and stitching each other, right? So whenever you have step 4 scan body scan, if you focus on only scan body, that meaning is there's not the right position information for scan body with our gingiva scan. So we should make sure we could scan with the neighbor teeth and scan body together. And we could expect the scan body position and neighbor teeth positions are correct, right? And then the last thing is provisional crown itself. If you would like to, we can just creating another work order and we can capture that, okay? I have just one more rear case view here. I just open up the dental system again. Same file, which you just saw. I just want to show you with the live within 3Shape software. We starting with scan body scan. Of course, we have the gingiva, we have a pre-op, but once we have scan body scan and we do align with the rear scan body to library scan body. After that, we can have implant position, right? And we could go with the design. Once we get into design, as you saw, if we have temporary itself, the scan file like this, whenever I design the custom abutment, we can expect and we can following the contour of the emergence very closely, very similar, and we can just make just like almost same as like the emergent profile. And then after that, once you have a nice emergent profile, the last thing is on the crown side for final crown, we can just duplicate of the neighbor tooth of the number 8. Let me just show you very quickly here. Okay. We can just mirror copy from number 8 to 9. Okay. So far the images are just like same as just temporary crown, but simply just with one touch click, I can just move cop from the symmetric tooth to the 4 final crown design. Okay. Oops. Okay. So 1 second. Let me just drawing up. Okay. All right. Just like spline is just go underneath here. All right. Okay. So within dental system from 3Shape, I think you guys already saw that we have a copy tools and the move cuff or copy from provisional scan and the neighbor scan. We have multiple tools to copy and paste. So abutment, contour, and tooth contour, we can just copy from the provisional and even with the neighbor too. So next step gonna be attaching a margin area and then smoothing down, and we could have a final design. Okay, so let me just go back to with my final topic here, the full arch restoration, like all-on 4, all-on 6. You already know the many case going on already with you guys. We already know like screw retain with the tie base and with the PMMA provisional trying first. Once it's good, switch to zirconia. Yes, we do a lot recently. And next, the option is this for making a highly aesthetic. Sometimes we want to make singles crown, not like bridge. We could mill out the prepped teeth bar, and we can make single crowns on it. It's all good, but actually for making the labor time and labor cost and the crown fee, actually the restoration fee gonna be high because a lot of steps and need to make all the singles. And very recently, I think from last year, some cases goes on like this way, okay, which is titanium, like about primary 2 to 4 degree titanium bar and zirconia whole bridge on top of there and bond each other. All the design which I show you today is all designs by 3Shape. That's what I want to tell you first. And which case is helpful and benefit with this style is like this. When we have some issue with the patient's bone or condition of patients, so if you couldn't place the implant on good position, so for the left one, we could have long pontic on the posterior. And then the second one is we have long pontic with the anteriors. So if you make just like one piece zirconia, we feel it's not comfortable because it could be broke. So with this kind of case, we can mill out the titanium bar, and then we can making a zirconia bridge on top of there. And this bar, I already sandblast out on the titanium. That's why it colors like that. So after mill the bar, we making a zirconia bridge on top of there, and then we do cementing on the laboratory side. All right. So once you're cementing out on the clinic side, on chair side, you just need to screw down it to the deliver. So then it's going to be just like same as just like any other screw retain bridge. Okay. So I think we make little pushing and rushing and make you guys like too busy to listen that and watching that. So all the things today from the Dr. Parks and Jack Jung here with the 3Shape and 3DBioCAD, we are always with you guys, and we want to telling you we focus on always making better and focus on the best. So I hope you guys enjoyed this presentation, and I'm gonna take over to Elisa again. Elisa, are you there?
Yes, I am. Thanks, Jack. Thanks, Dr. Park, for a great presentation. we can stay on for a couple more minutes. If anybody has any questions, please type them in the Q&A and chat, and we'll answer them live. I do want to make note that we will be sending an email out next week with an overview of all 3Shape promotions that you can talk to 3DBioCAD and that they can honor if any of you are interested in our products and software. So we'll turn it over to questions. If you have any, just type them in and we'll answer them live.
Mm-hmm. Yeah, you guys can chat it too if you have any question on Q&A chat, or just we have a Q&A chat on the center of the toolbar.
Actually, I have a question, Jack.
Okay, okay, that's good.
So when you're cementing the full arch zirconia onto that titanium bar, what do you cement it?
Oh, actually, the things for the cementing for the screw-retained type with the titanium to zirconia, as you show to everyone, I'm using very same way I do the sandblast on the titanium and the bridge inside of there, and also I'm using like resin-based cement like you use. I'm doing like the bonding, and also doing it's just like same as your clinical one. So. Okay. Yeah, it doesn't need to focus on the brand, but I can say I'm using very similar on the clinical one too. But it's just like a little wide range, so I have to using a little more material. That's all. Oh, yeah. And then Dr. Pong, you got a question here. So like
temporary the reline done intraorally. Okay, so with the immediate temporary, maybe I wasn't very clear. So what you do is. You have a shell temporary with positioning jig that gets placed, and in the middle you have the temporary abutment that's sticking out, and those two are not touching. Now at this point, what you do is you just inject flowable composite around that area, in that area, and then you cure it, and then once it's connected, you take everything out, and then you do it outside the mouth. So of course, like doing it inside the mouth, it will be much difficult to, especially the emergence profile area, to fill that area. So what you do is you take it outside and then fill it outside the mouth. Yeah.
Great, thanks. Well, any other questions?
Don't be shy, doctors. We still have like a lot of attendees are here.
Yeah.
So yeah, we're ready to taking any question about the software and the CAD/CAM flow.
Yeah, but
we have another question here.
Needle cap. Actually, what do you mean by a needle cap PVS impression? What's the next question? What do you use to polish the provisional? I use a Renford product. I think it's called, it's a PMMA polishing paste made by Renford. That's the one I use. And then I use a soft goat hair brush on a straight handpiece. I use at about 700 RPM. I brush with that. I polish with that, and afterwards I use a cotton ball on a straight hand piece without any polishing paste, and then I run it around the polished area. That will give a high shine, and then of course, like I said, wipe the area with wet gauze and steam clean the temporary before it gets inserted. Oh, I'm using an anesthesia needle cap. I actually never. Oh, so the question is, can you use an anesthesia needle cap, I guess, to hold a temporary, and when you're doing the scanning? I think you can. I think that might work. I tried holding it with my hand to do the scanning. It was really difficult to scan the temporary crown while holding it. It actually didn't recognize that the temporary was there, so it actually didn't scan anything. So that's why I do make that block with the lab analog in it, and actually that block with the lab analog in it, I actually used it for when we're doing the traditional impression, we need to customize the impression coping. So that's what I used it for in the past. But now with a digital protocol, I just scan, place the temporary crown on there and just do a digital scan. Okay. Another question is, and have time laying the eggshell. Dr. Wan, so the question is, sometimes dentists have hard time relining the eggshell. What is your technique for proper reline technique? Actually, maybe this video will go online on YouTube. So maybe if you can watch that, I'll go over the step-by-step on how I do this. So basically, I pick up the temporary abutment inside the mouth and basically fill out the any voids or and the emergence profile outside the mouth with flowable composite. Okay. Now the next question: can you hollow out? Okay, so next question is, if patient has a flipper, can you hollow out tooth and reline? Yeah, no, I think that's a very good technique. That's actually quite smart. So it's basically the flipper will be because you need a flipper anyways, right? Because you always need a plan B because you might not be able to immediately provisionalize. I haven't thought of that, but that's actually quite smart. Then you don't have to have two temporary restoration ready. You can just have one. Oh, very smart. I might use that next time. Okay. I think this question is for Jack.
Mm-hmm.
Okay.
So why did you do milled metal? Yeah, it was titanium, round-out screw bar, then cement all zirconia restoration rather than just all zirconia restoration. So yeah, I'm not sure if I understand well or not. If your question about why we go with like milled titanium bar for zirconia hole bridge is sometimes if we have like long span of the pontic area, we feel it's not very comfortable to avoiding it to breaking issue. So that's why instead of use just titanium, like a Thai base or titanium non-engaging abutment, we want to just making like substructure with the titanium bar, and then we just cement it as like a whole one piece, and we could expect we can avoiding a like breaking or cracking issue with our zirconia bridge. Okay.
Okay. And Dr. Derek Chua asked, do flowable dots on Ruge stick good? I think it sticks good enough for you to do the scan. So obviously, if the patient touches the palate after you place the flowable dots, obviously it might move, so that's not good. So just try to make sure that the patient doesn't touch it. One thing that I don't think I mentioned is for the lower scans, if we're doing a lower scan, obviously we can't do it. So what I do on the lower scan is I put a retractor like an Optragate or something, and then I apply dots on the buccal surface, buccal gingiva, not on the mucosa, but the attached gingiva, and then I use that to do the scan. Okay. Now, Dr. Donald Cole, if reline done outside the mouth for immediate provisional, so how do you capture the support the socket? That is, how do you support the socket, and how do you make sure that it fits? So the way I do this is when the lab is designing the temporary shell crown, they're going to make it in an ideal position. So let's say your soft tissue contour, the gingival margin is ideal before you took the tooth out. Then what the lab is going to do is they're going to make it the temporary shell so that it ends up right at the free gingival margin. So now I know where that margin is, and then basically what I do when I fill in the gap and create the emergence profile, I'm filling in everything underneath that free gingival margin. So it's not really going to alter the position of the soft tissue. And the article that talks about this a little about the critical contour and subcritical contour, I think it's done by Sue at UPenn. So they have an article on the critical contour and the subcritical contour. So basically, I'm creating the critical contour with the shell temporary, and I'm making sure that CEJ on the shell temp is super accurate. So this is very important that it's super accurate. And you really need to pay attention, and whoever's designing the shell temper needs to pay attention to that, so that it ends up right at the gingival margin, and have in a buccal lingual direction in all direction, I guess. Yeah. So that's how I control that the temporary crown fits well and supports the soft tissue. Okay.
I think, this question probably is gonna be last one, and I think the last question is how much room we need to I think your question is like from the implant platform from there to the zirconia bridges at your top, about for the making a restoration with the bar and zirconia height. I think I could just telling you, you can just think very similar with the other workflow, because anyway we just switch it to titanium base or abutment. Switch from titanium base or custom abutment or a non-engaging custom abutment to titanium bar. So like standard number, like posterior 12 millimeter and then anterior for 15 millimeter will work fine. But at least to me personally, when I have the case like under 10, something like that, it could very hard to making it, because anyway, even titanium bar, I want to making sure that bonded well and stitched well. So simply bar height could have at least 5 to 6 millimeter, and then should zirconia crown bridge should go on top of there. So I would recommend over 12 millimeter for posterior and then 15 millimeter for the anterior. Same as just common way. Okay. All right. I think Elisa, I think we cover all the question.
Yeah, thank you guys. So then again, next week we'll send an email overview of all the promotions, and if you have any other questions, please reach out to 3DBioCAD or 3Shape, and we'll be more than happy to help you. Thank you all for your time this evening.
Okay, thank you.
Thank you very much, everyone.
Bye.